Okay, let's unpack this. You might think you know your skin, but what if I told you it holds secrets, uh, hidden highways for infection, and even dangerous areas you've probably never even considered?
Hmm.
Today, we're doing a deep dive into something we often take completely for granted, our own skin and the subcutaneous tissue just beneath it.
Right.
We've poured through some really incredible sources full of surprising insights, and we're going to explore these structures specifically from uh, a surgical perspective.
Yeah, the surgical angle is key here.
Our mission really is to give you a shortcut to being truly well informed, understanding not just what these layers are, but why they matter so profoundly in health and, surgery.
What's truly captivating, I think, is how seemingly simple layers become these critical strategic considerations for surgeons. They impact everything from, say, successful healing to how infections might spread.
Exactly.
So we'll be extracting those vital nuggets of knowledge, helping you see the body's largest organ with, hopefully, entirely new eyes.
Okay, so let's start with the absolute basics, the body's outermost blueprint. Our sources show just how much surgical significance each layer holds.
Mhm.
We can use a simple mnemonic, STA-LP, to generally break it down, though, like for now, we're not just talking about the top of your
Right,
head.
it's a broader framework first.
This acronym helps us remember the skin, subcutaneous tissue, cutaneous nerves, and deep fascia. So what are the absolutely critical distinctions surgeons are focusing on in these foundational layers?
Well, that's a great question because those distinctions are, well, everything. First, the skin itself. It's made of two main parts. The epidermis, that's your skin's outer shield. It's completely avascular, meaning, crucially, no direct blood supply of its own.
No blood supply, okay.
Yeah, think of it like a tough, waterproof film. Then, just beneath it, you've got the dermis. Now, this is the skin's lifeline. Highly vascular, packed with nerves, hair follicles, sweat glands.
Uh-huh.
Think about a paper cut, usually no blood.
Yeah.
Right, that's just your epidermis.
Mhm.
But go a fraction deeper, and you hit the dermis, and bam, that dense network of vessels springs into action. This dual nature protective shield and vascular powerhouse, that's why surgeons treat it with such respect. Its health is just paramount for healing.
So the dermis is where the action is for sensation and blood. Okay.
Yeah.
Then, just below the skin, we find the subcutaneous tissue, sometimes called the superficial fascia.
Mm-hmm.
Our sources highlight two distinct layers here, a fatty layer, Camper's fascia, and then a more membranous layer, Scarpa's fascia, especially prominent in the lower abdomen.
Yes.
It makes you wonder, why do these two layers get special names and attention? What's different about them that gives them unique surgical significance?
Well, those aren't just textbook names. They point to critical differences in structure and function. Take the cutaneous nerves, for example, which run through this subcutaneous layer.
Yeah.
These are the sensory nerves that wire specific areas of your skin, what we often call dermatomes. Think of your skin like a geographic map, where each country or dermatome connects to a specific spinal nerve.
Ah, I see.
So if a surgeon is operating in one of these countries, they absolutely need to know which nerve lines to avoid. You nick one of these nerves, and what do you get?
That annoying tingling.
Exactly. That persistent pins and needles sensation, or even chronic pain, what we call paresthesia or neuralgia. That's precisely why surgeons are so meticulous, avoiding these nerves to prevent those power outages.
Makes sense. And the deep fascia.
And then there's a deep fascia. These are different, strong, unyielding sheets of tissue, like the fascia latae in your thigh. They're like tough, non-stretchable compression stockings for your muscles.
Wow. Okay.
And they're critically important in conditions like compartment syndrome. This is where swelling inside these tight fascial compartments can actually choke off blood flow to muscles and nerves.
That sounds serious.
Oh, it's a medical emergency. It might require a fasciotomy, a surgical incision, to literally slice open that fascia and relieve that life-threatening pressure. So yeah, a seemingly minor detail like the thickness or strength of one of these fascial layers can absolutely have life or death implications because it controls where dangerous pressure builds up.
And it gets even more fascinating when you realize these layers aren't, uniform across your entire body.
Not at all.
Our sources really highlight these Regis differences, which lead to unique challenges, unique characteristics. For instance, the scalp actually does have 5 distinct layers, which coincidentally also spells out SCLP. Skin, connective tissue, aponeurosis, loose areolar tissue, and pericranium.
Right, the scalp is its own special case.
Or think about your palms and soles, much thicker dermis, right? Great for gripping, more sweat glands, but no hair. Then there are those abdominal layers we mentioned, Camper's fatty layer and Scarpa's membranous layer, which actually extends down into the perineum as Colles fascia.
That connection is important, as we'll see.
But here's where it gets really interesting and, frankly, a bit alarming. The dangerous area of the face. You might be surprised to learn that the loose subcutaneous tissue in the face, especially around the eyelids, cheeks, and nose, while it allows for great skin mobility, for expression,
Yeah, all our facial expressions rely on that mobility.
it also creates a perilous pathway for infection.
Indeed.
Yeah.
And what truly captivates me here is how such tiny anatomical details can have these massive clinical consequences. An infection, like facial cellulitis or maybe an abscess in this area, can spread incredibly rapidly.
How so?
Well, from the facial vein, these infections can travel up to the angular vein, near the eye, then into the ophthalmic veins. And ultimately, because of these valveless venous connections, veins without one-way doors, basically,
Oh.
they can drain directly into the cavernous sinus that's deep inside your skull, right near your brain. And this can lead to a cavernous sinus thrombosis, a life-threatening blood clot in that critical vein network. The specific zone, the medial facial triangle, from the corners of your mouth up to the bridge of your nose, is considered particularly vulnerable.
So a simple spot could become really bad.
It's a prime example of how superficial infections can have deep, severe implications due to the body's intricate and sometimes, unforgiving network.
You just highlighted how infections can navigate these hidden pathways. That intricate network idea extends powerfully to blood flow too, doesn't it?
Absolutely.
So what does the skin's incredible vascularity mean when a surgeon is, say, trying to rebuild a part of the body or even just making a simple incision?
It's a double-edged sword, really. The skin has these rich anastomos, basically, many interconnected blood vessels.
Okay.
This is fantastic for healing. It allows the skin to recover quickly from injuries,
Mm-hmm.
but it also means significant bleeding during surgery.
Right. Makes sense.
This rich blood supply is absolutely crucial when designing flaps, where surgeons move skin and underlying tissue from one part of the body to another. Some flaps, axial flaps, rely on a specific major artery. Others, random flaps, depend on that general interconnected network of smaller vessels.
And where is this network?
This arterial plexus, this network of arteries, lies right there in the dermis, ready to bleed. And of course, the venous drainage system, with its superficial network, links directly to the deep veins, meaning blood has plenty of routes back to the heart.
And when it comes to nerve supply, we talked about dermatomes, that geographic map of sensation. What about the lymphatic system? How does that factor into a surgeon's thinking?
The lymphatics. They're critical, especially for understanding how disease spreads. The body has both a superficial and a deep lymphatic system.
Okay.
Knowing the regional lymph node drainage patterns is like knowing the body's postal routes for immune cells and, waste products.
Like delivery route.
Kind of, yeah. For instance, head and neck usually drain to cervical nodes in your neck, the arm drains to axillary nodes in your armpit, and the leg drains to inguinal nodes in your groin.
And why is that so important?
Well, it's incredibly important for understanding how infections travel and, critically, how cancers like melanoma and squamous cell carcinoma can metastasize or spread.
Cancer spread.
Exactly. Surgeons use this knowledge to track cancer's potential escape roads. It guides decisions about staging the cancer and planning treatments, like whether to remove lymph nodes. It really highlights the body's intricate defense and communication systems and how a surgeon must be acutely aware of them.
That brings us nicely to some real key surgical nuggets, the sort of rules of engagement for surgeons working with skin. First up, incision matters. Surgeons don't just cut anywhere, they respect Langer's lines. These are natural tension lines in the skin, almost like grain in wood. Why is it so important to follow these lines?
Following Langer's lines is essentially about working with the body's natural structure, not against it. Incisions made parallel to these lines experience less tension.
Less pulling apart.
Precisely. Which means less scarring and better cosmetic outcomes. It just promotes a smoother, stronger healing process overall.
Okay, better healing, less scarring. Got it. And then the fundamental principle of skin grafts. Our sources make it crystal clear. Grafts only work if the dermis is included.
Absolutely non-negotiable.
And what's the why behind that? Why is the dermis such a critical part of a successful graft?
It all comes back to that lifeline idea we discussed earlier. Skin grafts rely on capillary ingrowth from the recipient site, the place they're being put to survive. They need a new blood supply to grow in.
Okay.
The dermis contains that superficial vascular plexus, the network of capillaries, essential for this revascularization.
Hmm.
If you only take the epidermis, the outer layer, without the dermis, well, there's no capillary network for the new vessels to connect to.
So the graft just dies.
It essentially suffocates, yes. It becomes just a non-vascularized sheet of cells that's destined to fail. This is why split-thickness skin grafts include the epidermis and part of the dermis, and full-thickness grafts include the entire dermis for better durability and sensation, though they require more from the donor site.
That's a really clear explanation for how grafts work, but it makes me wonder, given all that vascularity you just described, all those vessels in the dermis, does that also create significant challenges during other types of skin surgery beyond just the graft needing a blood supply?
Oh, absolutely. That dense vascular plexus in the dermis means skin bleeds. Sometimes quite a lot. Surgeons need to be very aware of this, especially during things like flap elevation, where they're lifting a section of skin and its underlying tissue.
Right.
I remember a professor once telling us, if you think fat is just inert padding, try suturing through 10 centimeters of it. It's like working through a very vascular hidden minefield.
Ah, good analogy.
We also see issues like skin edge necrosis, where the very edges of a wound don't get enough blood and, well, die off.
Why does that happen?
It often happens in closures that are pulled too tight, or in patients with existing circulation problems, like in diabetes or in smokers, because they already have poor marginal vascularity.
Ah.
So the tip is always to incise cleanly. Jagged edges dramatically increase scar tissue formation and the risk of ischemia, which is just tissue not getting enough blood.
It sounds like the body's fat layer, the subcutaneous tissue, is far from just passive padding then.
Exactly. That's a key surgical reality. Subcutaneous fat, or superficial fascia, is not inert. It's vascular, it bleeds, and it can actually hide significant vessels, making surgery trickier than you might think.
Especially in larger patients.
Especially in obese patients, this layer can be over 10 centimeters thick. This increases dead space, basically, empty pockets left after closure where fluid can collect.
And that leads to
Seroma formation. Think of it like a persistent blister under the skin. It not only delays healing, but also creates a perfect breeding ground for infection. So yeah, obesity does not equal immunity here. Fat is actually prone to ischemia, infection, and it's harder for antibiotics to penetrate well. So this understanding significantly changes surgical planning and how we think about patient recovery.
That's a crucial insight, and it ties into this concept of perforators and flaps. What exactly are these perforator surgeons are so keen to find and preserve?
So the skin actually gets its main blood supply from deeper vessels that literally perforate. They punch through the muscle and fascia layers to reach the superficial layers, the skin and fat.
Okay, so they come from deep below.
Exactly. And surgeons need to know these hot zones for perforators, specific areas where these vital vessels reliably emerge. Think of the inferior epigastric artery in the abdomen, or the thoracodorsal artery, which supplies the big latissimus muscle often used for flaps.
So finding those is key for flaps.
Absolutely. The golden rule is, if a flap fails, loses its blood supply, you probably inadvertently sacrificed a critical perforator during the surgery. So the clear directive is never raise random flaps blindly. Surgeons should use a Doppler ultrasound, if possible, to actually map out and mark those critical perforators before they cut.
Fascinating. Okay, let's revisit Scarpa's fascia now, specifically focusing on its practical surgical importance, especially in lower abdominal surgery. You said it's not just a textbook name.
Not at all. It's a key player in the operating room.
Oh, so?
Well, Scarpa's fascia is very visible during lower abdominal surgery. And understanding it's a surgical plane, its exact location is crucial. For instance, in hernia repair, surgeons often talk about placing the mesh deep to Scarpas.
What does that actually mean, placement-wise?
What it really means is they're tucking the mesh much deeper, securely beneath a couple of strong natural layers, including Scarpas. It ensures the mesh is stable and gives a better long-term outcome, preventing it from ever being felt or seen right under the skin post-surgery.
Ah, so it's well covered.
Exactly. As one of our sources put it, in anterior hernia repair, the mesh sleeps under two covers, external oblique, and Scarpa never directly under the skin.
Nice way to put it.
Additionally, for surgeries on the lower limb, surgeons often place suction drains specifically between Camper's fascia, the fatty layer, and Scarpa's fascia, the membranous layer, to prevent those seromas, those fluid collections we just talked about.
Okay.
And vitally, Scarpa's helps anchor the suture line, especially in lower abdomen closures. It provides a bit of strength, contributing to a strong, lasting repair.
Okay, but now, Here's where it gets really interesting, maybe a bit scary again, showing how these fascial planes can act like highways for infection.
Yes, the flip side of these defined planes.
When things go wrong, these structures, which usually protect us, can become pathways for some really aggressive diseases.
Yeah, the striking thing is how quickly infection can spread along these fascial planes. They truly can act like highways for pus. A vivid and frankly terrifying example is Fournier's gangrene. It's a rapidly progressive necrotizing fasciitis, a flesh-eating infection, essentially of the perineal area, the groin, and it can spread incredibly fast via callus fascia, which, as you mentioned earlier, is just a continuation of Scarpa's fascia down into the perineum.
Wow, so Scarpa's is connected right down there.
Directly connected. The rule here is stark, and surgeons know it want. When pus spreads under fascia, speed saves limbs and often lives. It highlights the critical importance of early diagnosis and very aggressive surgical intervention, cutting away the infected tissue.
It's incredible how the body's design can be both a blessing and sometimes a curse in these situations.
It really is.
Beyond rapid infection spread like cellulitis or necrotizing fasciitis, our sources also touch on other pathologies where the skin structure impacts the disease. We see common skin cancers like basal cell carcinoma, BCC, squamous cell carcinoma, SCC, and melanoma. What's the key surgical consideration for these?
For those malignant tumors, the critical thing is always the depth of the tumor, how far down it is invaded through the skin layers, and whether it is spread to the lymphatic system. That dictates the treatment approach and the patient's prognosis.
And other issues.
Well, you see things like pressure sores, which typically develop over bony prominences where there's poor blood supply meeting constant pressure. And then there are keloids and hypertrophic scars, which are essentially an overactivity of the fibroblasts in the dermis, leading to that excessive raised scar tissue formation.
But beyond the really serious stuff, our skin also throws up some fascinating, sometimes just peculiar bumps and spots that aren't necessarily dangerous.
Oh, absolutely. Common things.
We've all probably seen or felt a lipoma, right? That's the most common benign fatty tumor. Usually feels mobile under the skin, easily excised if it's bothersome.
Very common.
Then there's the sebaceous cyst. That's a retention cyst caused by a blocked gland duct. It often feels fixed to the skin, sometimes has a little central dot or punctum, and you see them a lot on the face, scalp, or scrotum.
Yes, those epidermoid cysts.
And let's not forget congenital conditions like neurofibromatosis type 1, NF1, which can show characteristic skin findings like cafe au lait spots or freckling in unusual places.
Right, those are important diagnostic clues. But, even some of these seemingly simple observations can hide deeper lessons or historical context. Consider Koch's peculiar tumor.
Koch's peculiar tumor, what's that?
It's an older surgical term, not used much now, but it described an indurated, meaning hardened, ulcerating growth, found particularly in the groin or perineal region. Often it originated from some kind of chronic inflammation or infection, like old tuberculous lymph nodes or hidradenitis suppurativa.
Okay, so why peculiar?
The peculiar part and the crucial lesson is that these long-standing chronic inflammatory masses could undergo malignant transformation, turning into something resembling squamous cell carcinoma, a kind of cancer arising in a chronic wound, sometimes called a Marjolin's ulcer.
Ah, so it raises a question.
It raises an important question exactly. Why should any chronic ulcer or area of chronic inflammation always be biopsied if it suddenly changes, gets harder, or starts growing? Because, as Koch's peculiar tumor teaches us, seemingly benign, long-standing issues can harbor or turn into cancer. Vigilance is key.
That's a really good point. And you mentioned another interesting one, the sebaceous horn.
Yes, the sebaceous horn, which is actually a bit of a misnomer. It has nothing to do with sebaceous glands.
Oh, so what is it?
It's a hard, conical projection made of keratin sticking out from the skin. It literally looks like a tiny animal horn.
Wow.
What's truly captivating here is the crucial surgical principle. You must always biopsy the base of the horn. The horn itself is just dead keratin, like a fingernail.
Okay.
But the underlying pathology, the reason the horn formed, which could be benign like a wart, premalignant like actinic keratosis, or even frankly malignant like squamous cell carcinoma that lies hidden beneath the keratin at the very base of the horn.
So the horn itself isn't the issue, it's what's underneath.
Precisely. So we have a helpful mnemonic here. Horn points up, danger lies beneath. It perfectly encapsulates the need to investigate the source, not just the superficial manifestation.
What an incredible journey we've taken. Seriously.
Yeah.
From the general scallopy blueprint and the specific dangers of the medial facial triangle
Hmm.
to the hidden anchors of Scarpa's fascia and those surprising truths about fat, it's clear our skin is so much more than just a surface.
It really is. It's a complex, dynamic organ, absolutely vital for surgical success and for understanding countless aspects of our health.
Yeah.
What this ultimately tells us, I think, is that every layer, every cell, every vessel plays this crucial role in our overall health. Understanding them helps us appreciate the body's incredible resilience, but also its vulnerabilities.
Right.
It informs everything from diagnosis and treatment to even preventive care. It's really a testament to the intricate, interconnected design of the human body.
Well, thank you for joining us on this deep dive into the skin's surgical secrets. We really hope you feel a little more well-informed about the amazing organ that covers you from head to toe.
And maybe as you go about your day, just consider how everyday observations of your own skin, new bump, maybe a cut that's slow to heal, or even just noticing how freely your facial skin moves are actually subtle clues to the complex architecture and the potential stories hidden just beneath the surface.